All right. So I'm Brent Keith. I'm a pediatric GI.
Okay. My home office is down in Plano, and we see kids with GI problems. And kind of the way that first,
Thank you guys for feeding. Thank you for inviting me up here to talk. I'm going to structure this kind of in a way that is, when I talk to people sometimes, I'm sure just like when you guys talk to people about your jobs and you're like, well, like, what do you do there? And because I think people have a hard time sometimes thinking like, kids have stomach, like what kind of stomach stuff do you guys see? So I kind of run by this talk was made, trying to hit some of the high yield stuff that we do on a regular basis. Feeding is in here, but lots of other stuff is in here too. So it's kind of a high yield potpourri of stuff that we do on a regular basis. So I'm Brent Keith. I'm a pediatric GI. I specialize in seeing infants, children, and teens with GI or gastrointestinal problems. My home office is in Plano, but I go to Sherman, I go to Grapevine, I go to Prosper.
and I go to each one of those locations several times a month to see kids. We kind of go where the people are. Sounds like that's kind of y'all's model here as well.
I'm a fellow Texan. I've got a lovely wife and 3 kids. And I've been practicing pediatric GI for 16 years, not including 3 years of fellowship to be able to do it. I was formerly an associate professor of pediatric GI at LSU in New Orleans. I drank the Kool-Aid, had the punch, and I'm a diehard Saints fan, and I love me some LSU as well. That's where I learned about saltwater fishing, and so we go back as often as we can to do that stuff with my kids. But I got lucky enough to come back here and serve the community and the kids, and so I've been back here for 4 years now. And so when I'm not working, I enjoy active lifestyles. High rocks, we've already talked a little bit about that, and as little indoor stuff with my kids as possible, and as outdoorsy as we can be is the goal. So again, I already mentioned kind of some hot topics that we're going to talk about today. This is, I think, in order, but I don't think it's in exact order. But abdominal pain, constipation, vomiting, reflux, diarrhea, difficulty swallowing, inflammatory bowel disease, some GI bleeding, DGBIs, or disorders of gut-brain interaction, which used to be known as functional gastrointestinal disorders. And then we also are going to hit on procedures as well, because I get lots of questions about procedures, and people they didn't know that you can do a colonoscopy on a 2-year-old, and you can, and is it scary? And there's a lot of questions that were asked, so I'm going to kind of walk through that a little bit and dispel some myths. So probably the most common thing that we see kids for is abdominal pain. Probably the most common. And when we see kids with abdominal pain, we have a job. We have to figure out, do they sit on the organic pain side, or do they sit more in the DGBI, or disordered gut-brain interaction, or functional abdominal pain side? So organic pain, I want you to think about as disease. Disease usually causes blood, or pus, or tissue damage, or fevers, or inflammation. So usually that type of pain is more point specific, rather than my belly kind of hurts me over here one day and it hurts me over here this day and it hurts me only in the evening. That would be more of a DGBI. So shorter duration of symptoms. I've had pain for a week rather than I've had pain for 3 years and I'm still growing and thriving and doing what I want to and going to school. Shorter duration of pain for me is going to put me more on the organic side of things, the disease side of things, versus over here with a DGBI. DGBIs, or functional abdominal pain, is all about sensitive nerves in the GI tract. It's not about blood and pus and inflammation and tumors and blockages. This is the sensitive nerve category. So if you look, depending upon where you look, you're going to see, hey, greater than 25% of kids are going to have a sensitive nerve diagnosis. We did a study at LSU while I was there. A fellow did, and they enrolled like 1,200 kids, and like almost 60% of them had a DGBI diagnosis or a sensitive nerve diagnosis. So there's a lot of kids out there with this. It's not always about disease, is the point. So these are all symptom-based criteria. There is not a test that you can do that says, hey, here's the blood test, and it says, look, you have a sensitive nerve diagnosis. Nope, doesn't work like that. That's nice for parents to be able to see, especially if you say, hey, look, the liver numbers are off, and this is how we're going to fix it. That's a lot easier to conceptualize and see. But it's harder to go, this is our diagnostic criteria. If you've had abdominal pain for this long, and you've had nausea for this long, and you don't have red flag signs, then that equals this disease. That's how these DGBIs or functional abdominal pain syndromes work. These symptoms, like I've already mentioned, are way more chronic. They've been happening a long amount of time. You meet a 10-year-old and it's been happening for half their life, but they're 5 foot tall, they're 130 pounds, and they look really healthy. Probably less of a disease issue. That automatically just puts me over here rather than that patient has Crohn's disease, which would be over there. So that pain, like I already said, tends to bounce around. This pain can also worsen with central nervous system stressors, school time. We're about to see a lot of this kick up. Labs, scopes, imaging, if you need them, if you need to do them, are normal, okay? But a majority of the time, we try and not over-medicalize too much, because as you do tests, and each test comes back negative, anxiety and worry heightens, and people go, well, we're just missing something. Something is there, you're just not finding it. So it's a lot of patient education when it comes to these DGBIs, and making sure that they know what we think is going on, and it's not disease. So examples of organic pain, as I've kind of already hinted at, Crohn's disease, reflux disease, pancreatitis, gallstones, infectious diarrhea, like with E. coli or salmonella or this new thing in the news, right? The lettuce bacteria or parasite. I'm sorry. So treatment depends on the disease, right? So treatment is targeted at whatever specific disease you have. If you have a DGBI or disordered gut-brain interaction or functional gastrointestinal disorder, treatment is here, but some of those examples, irritable bowel syndrome, how many people have heard of that? Lots of people probably, right? So that's like 1 in 4 people, very common. That's about sensitive nerves, that's not about disease. Functional constipation, these are kids that pass big giant pieces of poop out of their hiney's and it hurts them and they hold on to their poop and they come in and they are in lots of pain and they have soiling in their underwear and there's a lot of parental anxiety around it and the kiddo is embarrassed. And it's not about disease, it's about pain. Take the kid out of pain because of the big poops, and the kids get better. Functional nausea is where you have nerve-mediated nausea, not disease-mediated nausea. Sometimes that takes a little bit of digging around to figure out. There's something called abdominal migraines and cyclic vomiting. These are very common things. We see these a lot. Abdominal migraines are the same thing as a head migraine, except it happens in the belly. So it's bad, horrible episodes of abdominal pain that lots of times they'll lead to going to an emergency room, they get CT scans, they get worked up, everything's negative, and they keep having these continued episodes of bad, horrible pain. Eventually people go, uncle, we don't know what this is, and then they end up seeing us, and that's the diagnosis. Cyclic vomiting is where kids, instead of having bad episodes of pain, they throw up a whole lot. Sometimes they'll throw up 10, 15 times an hour and can't even keep fluids down, and they require an emergency room visit. And it's not about disease, it's about sensitive nerves. Depending upon the severity of their symptoms, lots of people want to do tests. And I think some of those kids do deserve tests to make sure that things are not obstructive or there's not a surgical problem going on or an appendicitis going on. So you have to tailor it for each individual patient. When you talk about DGBIs, you have to address the brains and the guts. For organic disease, lots of it is treating the disease. But for DGBIs, you have to treat the brains and the guts. I've already mentioned you have to be careful to not over-medicalize as it causes more worry and more panic. We use neuropathic pain medicines to make that better. Lots of times we have to get psychology involved and psychiatry as well. Cognitive behavioral therapy helps, relaxation techniques, breathing exercises, things like yoga, meditation also helps the brain, which in turn helps the guts. This is the biopsychosocial model. Same exact picture on both sides. I don't know why I did two. But the point is that with any of these DGBIs or functional GI diagnoses that we see that include sensitive nerves, we have to think about the whole person and their surroundings, not just looking at the disease. We have to look at the person's environment with which they live. We have to look at how the person themselves deals with stress, right? So it's not just about, hey, look, there's disease, or hey, look, they're in pain. You have to look at all the factors that may influence that and go about it in a multimodal kind of a way, not just, here's reflux medicine, hope you get better. This is probably disease. You may be missing it if you're not asking about school bullying. You may be missing it if you're not asking about school stressors or home stressors even. So it takes time to get a good history, but it's worth it. So I'm going to move on to constipation. So this is a typical history, probably beyond abdominal pain, second most common thing we see. So typical history that we would hear, 7-year-old boy comes in with big giant poops every week. When he does poop, he screams, he cries, it hurts. Things seem to get really bad during potty training when parents wanted him to not poop behind the couch anymore, they wanted him to poop on the potty. He gets on his tiptoes, he scissors his legs. It's a fight to get him to sit on the potty. He won't go without being told. He walks around with poop in his undies. It doesn't bother him. It bothers the parents. Friends are starting to notice it. He's a busy guy. He always is on the go. He wants to be outside. He wants to play video games. He just can't sit still. Sitting on the potty isn't a priority for him. During the visit, he's looking out the window. He's hiding behind mom's chair. Visually, he seems to be embarrassed about being there. Mom sometimes sees blood in the poo with the big toilet clogger poops. So when it comes to constipation, we have to think about disease. Always we have to think about disease and not have it just be a typical history like this, which is most likely a kiddo with functional constipation. So disease is out there, we don't want to miss it. It's in a good history and it's in a good physical exam. Delayed meconium passage. Do you guys know what meconium is? That black stuff that babies poop out right when they're born. If babies are pooping that out in the first couple of days and a week or two later they're still passing meconium out, you need to think about the plumbing and the pipes. Or is everything open? And if it's not, then you need to be doing some contrast studies to figure out what that baby's anatomy is. Pencil thin poops, same kind of deal. If the poops are teeny tiny and thin and the kiddo's not having like an age appropriate poop where you're like, why is the poop always that teeny tiny and small? You better do an anatomy study, you better check it out and make sure that his anatomy is okay. Blood in the stool, always a red flag sign. Always should be checked out, always should be brought up. That could be anything from, the big one that you don't want to miss in a kiddo that's constipated would be something like a toxic megacolon from a Hirschsprung's, which is where poop can't get out and poop backs up and it causes dilation in the colon, and then the colon starts to get real sick real fast. And there's lots of inflammation up there and they can perforate and pop. So you don't want to miss that one. Those are kiddos that you're not seeing usually as an outpatient. Usually those kiddos are usually sick enough to be in the hospital. If they're having pee issues and poop issues, that could be a potential problem. If they're having problems controlling their bladder or they're peeing when they don't want to and they can't control their poop, we need to be thinking about the spinal cord. We need to be thinking about potential pelvic masses, things like that. Kiddos that come in with back pain, a 5-year-old that comes in with back pain, that's a little weird. 50-year-old that comes in with back pain, that makes sense to me. 5-year-old, why does a 5-year-old have back pain? And you can't poop? That's a little odd. We probably need to look into that. Or a kiddo that hasn't pooped for a while and their belly gets big. Not like a little pudgy, but like big. Their t-shirts hanging off their clothes. That's a kiddo where we don't need to be talking about behaviors and in hard poop and how to make it loose, but we probably need to be doing some imaging and looking into that a little bit more. Beyond these common things, or less common things, this by far, functional constipation is by far probably the most common reason for constipation that we see in clinic. So it has to include, I don't know what that means, greater than 4 years old. This is in a kiddo, so there's different criteria depending upon your age. There's criteria called the Rome criteria that are made up by a group of physicians that give us those criteria that say, hey, you don't have to do a bunch of testing in these kiddos. If they meet certain criteria to make a diagnosis, that's their diagnosis. This is an example of Rome criteria diagnosis. So in a kiddo who's greater than 4, it must include a greater than or equal to 2 of the following occurring at least once per week. So big toilet clogger poops, large poop ball on exam that you're actually physically feeling, history of hard poops. So basically they have to meet 2 of these to make a diagnosis of functional constipation. So these are a couple of examples of those anatomy studies I was talking about. So this is a picture here of a normal x-ray that has a bunch of soft poop in the rectum. Okay, I do that makes me feel better. Do we need to do x-rays on every kid that comes in with constipation? No way. No way. We'd be irradiating too many kids. If there's something suspicious on your exam or suspicious on the history, then we do x-rays. So if you go to your PCP and they're not doing x-rays, that's okay. So this is called a barium minima. This is where they take some contrast and they're going into the rectum, into the anus, and they're squirting contrast to look at the anatomy. And what you're looking at here is this real narrow spot right here. This is not normal. So this is where the nerves don't go all the way down to the baby's bottom, and the baby can't get poop out. And as a result, see this area that looks like a balloon? That's the well area. Poop can't get out. That's the area that doesn't have nerves, and it can't relax, so it stays tight. So in this baby, this is a surgical condition that we would ask the surgeons to get help with. This is a cool study that anybody can do. This is called a sitz mark study. It's kind of far away, maybe, or maybe small. I don't know if you can see it, but you see those little round circles in there? Those are called sitz markers. And sitz markers are teeny tiny rubber bands that show up on an x-ray. And what you do, obviously you're not going to do this in a baby, but you would do it in maybe like a 5 or 6 year old. You dump them in some applesauce and you have the 5 or 6 year old swallow them. And then on day 1, you take an x-ray, and then 5 days later, you take another x-ray. And you go, where are all those markers? Is there something blocking? Is there something blocking the poop? Are all the markers stuck over here on this side of the colon? Can the colon not push it? Maybe the kiddo has a nerve or a muscle problem. So it's a pretty cool little study that you can do without being connected directly to a motility center. When you are, some of the bigger academic centers around here, they have the ability to look at the neuromuscular health of the colon. If you don't have access to those types of centers, you can start out, or your PCP or GI can start out by doing this. That gives you a rough idea of what that colon's doing, and are the pipes open, and are things moving through. That's called a sitz mark study. So other things that you can do to look into constipation a little bit more: thyroid studies. Celiac shows up with constipation sometimes. Electrolyte abnormalities will cause constipation sometimes. And then less commonly now, just because we don't see it in paint, but lead levels. So functional constipation treatment, how do we treat it? Lots of patient education is how we fix it. You have to do 2 things to fix it. You have to make poop soft, and you have to change behaviors. And most of the time, making poop soft is really easy in a 3-year-old. Changing behaviors is the hard part for those who have had a 3-year-old. So you have to talk about how the colon works and how it makes poop, so the family understands how the medications work. You want to make sure that you give them stool softeners. So many families want to do it with diet alone. Oh, let's just increase fiber. Let's just give them more celery. I think that's a great idea, and I would never discourage it, but usually it's not enough. You need some more oomph behind it. You need something else to make the stool soft. That's where medicines come into play.
Would you say that that's like just at first, you kind of need that extra from medication, you know, to kind of correct the problem, and then you can go to dietary changes, or it's kind of something that's you need long-term medication?
The I think dietary changes are fantastic,
Yeah.
and it's good to write them down on a chart. It's good to talk about it. But at the end of the day, a 5-year-old's palate is going to dictate
Sure.
how much change you can actually make, right? And so many times you have to mix like stool softeners and things that they like to drink.
Sure.
So I would say a majority of the time they still need to be on something, because what you need to make go away is pain memories. Pain memories of big poops coming out, and as long as those pain memories are there, that kiddo is not changing his stool withholding behaviors. He's going to do the same thing. So you have to make those things go away. The biggest thing that dictates whether or not the patient's going to succeed in fixing constipation is the patient has to be open and willing to change. If the kiddo is cool walking around with poop in his undies and smelling like there's poop in his undies all the time, it's really hard to fix it because he's not motivated to change, right? But if he goes, this isn't normal. Like, I'm the only one at baseball that smells like that. I see that. Now all of a sudden there's motivation to change, and it's a light bulb, and they can change in a week or a couple of days. But it's helping them get there. Accountability to me is a big thing because it takes mom and dad out of the loop. And then sometimes we have to pull psychology in to help. So let's move on. Vomiting and reflux and rumination. So these terms are confused in clinic, and that's why I just want to go over them real quick. So vomiting, that's forceful expulsion, powerful, flying out of the mouth of either food or formula. Okay, so contrast that with, let's jump down here to rumination. Have y'all heard of rumination syndrome? Rumination syndrome. So we see this a lot. Parents will come in and they'll say, hey, my kiddo, everything they eat, like immediately after they eat, it's coming back up in his mouth. It's not, and they usually say it's vomiting. So, and then I have to like show them, like, is it like this? And I like ruminate. I don't really ruminate, but, or is it like forceful, like, and I do like, I'm an exaggerated like vomiter. And they're like, oh no, it's not forceful like the second one. It's like you don't even know he's doing it unless you pay attention. I'm like, that's rumination. So that's the passive regurgitation of recently ingested food into the spit out, or that's either spit out or re-swallowed. That's a DGBI. It's not a disease. Okay, that's where the kiddos are relaxing the bottom part of their diaphragm after they eat, and they're allowing, and the bottom part of their diaphragm makes up that muscle that separates the stomach from the esophagus, and so food comes back up. I'll talk more about that in just a second. And then reflux versus GERD. So reflux is more passive. If it comes out of the mouth, it's more passive. It just dribbles out, right? Or it can be silent. Lots of families come in. I'm sure you guys have heard it too. Lots of families will come in. I can hear it in the back of their throat. I can hear it in the back of their throat. So that's reflux, okay? But the baby's otherwise happy and growing and doing what they want. GERD is when reflux symptoms get in the way of something else. So in an infant, for example, they're refluxing so much that they can't keep calories down, that their weight is mediocre. It's not awesome. So that would be an example of gastroesophageal reflux disease rather than reflux. And then in a teenager, GERD, those are kiddos that will come in with heartburn. They're like, oh, it hurts right behind the bone in my chest. It's bothering me. Every time I eat, I scoped a kiddo this week, and he had Downs, and every time he ate, he cried. And he couldn't communicate that, but every time he ate, he cried, and the bottom part of his esophagus, I have a picture that I'll show you in a second what the bottom part of his esophagus looked like. It wasn't his, it's another picture, but it was raw and super irritated from reflux. So, vomiting. So common diagnoses that we see that involve vomiting. It's really hard to hit on everything, so I just try to hit on the most commons here. So bugs and infections. So short term, right? It's been happening for a couple of days. They were completely normal before, and now all of a sudden they're throwing up, or they've got maybe some diarrhea, and maybe they have a little bit of fever. That's a bug or an infection until proven otherwise.
cyclic vomiting syndrome. I've already mentioned that one. That's where you throw up a bunch and then it comes in cycles. That's why they call it cyclic vomiting. So you have these periods where you will throw up for hours to days, and you throw up multiple times. You feel really bad. Nausea is horrible.
Way more horrible than the vomiting is. Usually it's just horrible nausea, and you're also throwing up. You can't keep any liquids down, and you feel bad like that for hours to days, and then the episode abates, and you feel fine again until the next time you have an episode, which is about 2 to 4 weeks later, and it happens again, and it's the same thing. And you go to your pediatrician, and the pediatrician goes, well, it's probably a bug again. You know, they're in school, there's a lot of bugs going around. And then you're like, okay, supportive care at home. And then 2 to 4 weeks later, same thing. It's the same, almost transposable each episode. That's cyclic vomiting. Eosinophilic esophagitis. Do you guys know what that is? Right? So the way I describe that to parents is eosinophilic esophagitis is like asthma of the esophagus or the food tube. Instead of the allergy happening in the lungs, it happens in the food tube. And depending upon your age, it should manifest with different symptoms. Vomiting is pretty darn common no matter what the age. So these are some common things that we would see with vomiting when a patient comes in with vomiting. When they're new, especially infants, you need to be thinking about anatomic issues always. You don't want to miss a malrotation. You don't want to miss a duodenal atresia. And I'll show you examples of these in a second. So you always need to be thinking about anatomy issues with babies. Big kids too, frankly, but babies for sure. When to seek GI help or go to the ER. Weight loss or changes in eating habits. They're puking and they're not able to keep calories down, or when they do eat, they just throw their food back up, and now they're 5 pounds down in 2 weeks.
Probably don't want to sit on that too long. Anytime there's blood coming out of any hole, probably want to get that looked at. Repeated bouts of vomiting with normal periods of health in between. I talked about
that. That was that, cyclic vomiting. There's ways to treat cyclic vomiting. So that's what I'm saying. You probably want to seek help. GI would be a good place to go. Prolonged vomiting episodes greater than 48 hours associated with diarrhea and fever. My concern with that would be dehydration. A kiddo that's vomiting and dehydrated is going to look 50% sicker if they're dehydrated. So some fluids will do that kiddo some good. Decreased urine output, sunk eyes, minimal tears. These are all red flag signs for significant dehydration. The smaller they are, the less forgiveness they have. They just don't have the fluid volume to be able to vomit and have diarrhea very much before they get profoundly dehydrated. The bigger you are, the more cushion you have. The littler you are, the less cushion you have to get sick or to get dehydrated. Let's see. Oh, headaches. That's a big one. Headaches and vomiting. Always red flag. I always tell my people, if you have headache, if you have progressive headache or headache right when you wake up in the morning with vomiting, we need to know that. Okay. We don't often find bad, ugly things in the head, but they're out there and we don't want to miss them. And then this happens. They get stuff stuck in their esophagus. So they get a GI Joe, they get anything. They get stuck and then they try and swallow and they can't, and so things are coming back up and they're coming in vomiting. Well, that's because they got something partially blocking their esophagus. So this is an infant with reflux. So this is a happy spitter, right? So just look at the kid, right? So look, he's got wrist rolls. He's got rolls here on the corners of his arms. His big old fat cheeks, right? He's smiley. He's drooly. Like, he looks like an otherwise healthy kiddo that's spitting up, right? So that's a happy spitter. So that's infant regurgitation. We see a lot of this. And these are kiddos that parents will come in like, just won't stop spitting up, or she won't stop spitting up, and we're constantly having to do laundry. And you look over at the kid, and the kid's like super happy and smiley, and he's at the 75th percentile, and you still do a great physical exam, you still take a really good history, and that visit is about a lot of reassurance. And usually, even though that's the first time I've seen the kiddo, I'll probably see them back one other time. Why? Because you want to make sure they're gaining weight. Lots of times from pediatricians, we have one slice in time. Usually, we're lucky if we have a growth curve, but most of the time, the first time that we've seen the kiddo is the time in clinic. We have that one growth plot. So it's hard to say where they're going on the growth curve until you have at least two. That establishes some type of trend. And then it also, I don't know, like I just think it's good to see these kids back at least once before you go back to your pediatrician. I think everything is okay. So these are happy spitters. Contrast that baby with this baby. So look at this baby. So you can kind of see this extra fat, or not fat, extra skin folds here. You can almost see little abdominal muscles almost sticking through. You can see the ribs, right? Where's those fat rolls on this leg? They're not really there. Look at the tricep skin folds. So, like, that baby needs more subcutaneous fat. You really can't see the baby's face, but that baby needs more subcutaneous fat. That baby needs better nutrition. So, and then you have a pediatrician growth curve, and this is what it looks like. We were trucking, and then we started to fall off. So this is a baby, and parents come in and say they're spitting everything up, right? So this isn't a baby where you'd be like, I think this is infant regurgitation. This is a baby where something's going on, and we have to figure out what's going on. So if we're lucky, it's a bunch of reflux, and we can fix it, but you've got to look for other things at the same time. So briefly, without getting too much in the weeds here, so gastroesophageal reflux disease is when reflux gets in the way of something else. You need a good history, which includes birth history, developmental milestones, choking with feeds. Maybe the kiddo's got a little bit of blood in their poop, and maybe they have cow's milk protein allergy and their stomach is just upset from that. We need to always make sure that the reflux in a baby looks like the milk when it comes back up. We don't want it to be green, we don't want it to be yellow. Green or yellow equals obstruction until proven otherwise. That baby needs contrast studies and anatomy studies to make sure that the pipes are open. We need a good physical exam. Does the baby look syndromic? Does the baby look like the baby has like a genetic syndrome of some kind? Does the baby have a heart murmur? Is there anything else that is on the baby's physical exam that could be off or different? If there is any red flags, you need to be thinking about some type of a workup for this kiddo. Usually one of the first places that I will go to, I want to make sure the pipes are open. I want to make sure that the baby's anatomy is okay. And you would do that maybe with a contrast study or an ultrasound. And I'm going to show you that here right now. So contrast study is this, right? So where the baby swallows contrast, it goes down, highlights the stomach, and then it comes out. So in this kiddo, this is an example of malrotation, which is this. Okay, this is normal anatomy, how the stomach comes down, goes into the small intestine, and then the small intestine crossed all the way back over midline. And that's because the intestines are anchored by this tissue in the back. With malrotation, the intestines don't twist correctly in utero. And so all the intestines stay on this side. And when that happens, the chances for these intestines to twist is there, and it's high. And so what will happen is the intestines will twist on each other, and now things don't get through anymore. So that's going to be concerning for, there's malrotation, and when they twist, it's called a volvulus. And when they twist parts of the intestine, the blood supply can be compromised, and it could be a possible surgical emergency. So you don't want to miss those kiddos. This is another thing that we'll see sometimes. This is in usually a couple of weaker. See this muscle right here that's all thick? So that's pyloric stenosis. And that's the muscle as you exit the stomach. It gets thick, and it gets so thick to where nothing can exit the stomach. And so what happens? Everything comes back up. Okay.
Why did I say green or yellow? This may be too in the weeds, but I want you to understand. So the green and the yellow enters the small intestine right here.
On the liver. Okay. If there's a blockage further downstream, all that green and yellow that dumps right here can't go down anymore, and so everything is going to be coming back up. So blockages are going to be, they're going to equal some type of green or some type of yellow coming up with the formula. This one won't be that way because the green and the yellow, the bile enters down here and the blockage is in the stomach. So everything, those kiddos just come in throwing everything up and they're wasted and they're really small. Because they've been throwing up, usually they need IV fluids, and that's something that has to be fixed by surgery. So this is to investigate reflux further. You can do a pH probe, okay, which is this little tube that goes into the kiddo's nose, okay, and this is an example of what it might look like going down. So once the pH probe, and you can also do something called an impedance. pH probe looks at acidic fluid going back up into the esophagus. That's what this monitor is watching for. It's watching for acid that splashes up. But not all reflux is acidic reflux. Some of it is non-acidic. So if this just had acid probes on it, it wouldn't pick it up. So we have probes now that pick up acid and non-acid reflux. So you can see what's going up the baby's chest. And you can use that to correlate symptoms
with reflux events. So reflux, this is really primarily infant reflux, how to help those babies. So
reflux precautions, most families are already doing that by the time they get to us, right? Upright for at least 30 minutes after feedings, frequent burping. Trial of a hypoallergenic formula may be appropriate. So what you're getting at there is cow's milk protein allergy. And that's just a baby's body not recognizing cow's milk protein as being something that's beneficial. They're looking at it as something being foreign, and that's their body's reaction to that protein. It's, I don't like it. And so most of the time they'll show up with blood in their poop in an otherwise healthy kiddo, but sometimes they're fussy and they're mad and they're colicky and they're spitting up and they've got loose poops, and you go change the formula and everything gets better. If they're spitting up a lot, you want to try and, what makes it better is growing them. So if they're spitting up a lot of their calories, sometimes condensing helps, going from 20 calorie per ounce formula to 24 or 26 or even higher sometimes, trying to get caloric density down so the baby's at least seeing enough calories to be able to grow. Sometimes if milestones are being met and the baby's got good head control, you may consider starting some purees a little bit early because those are thick. And the thicker they are, the easier they're going to stay down. Thickening sometimes. Oatmeal, rice cereal sometimes. That may be a benefit. The minus part of thickening is it's carbs. It's carb calories, okay? So it's not ideal, but at the same time it's calories. And if it helps the baby keep stuff down, then that could be a possible strategy that you use. Acid suppression, I'll play with that sometimes for troublemakers where we're debating, like we're just trying to put any weight on this kiddo. The kiddo's fussy and mad. Maybe reflux is making the kiddo madder. Growing them fixes reflux. So weight gain is the most important thing. So the other thing I have to think about is oral aversion and gagging maybe leading to vomiting or reflux. Do they need a modified barium swallow? Do we need to be sending them for a feeding evaluation? I think when you're talking about getting calories in, does this kid need to potentially be admitted? You're like pulling everybody in, all brains, trying to figure out how to help this kiddo. And a feeding evaluation is part of that. So rumination syndrome, I'll hit on this again. So passive regurgitation of recently ingested food into the mouth that's either spit out or re-swallowed. It's harder to tell in an infant, obviously. So the kiddos that I see do this, usually toddlers to older kiddos. I had a 16-year-old this week that had it. Toddlers, and I've seen it in kiddos, like a toddler, I've seen it when a newborn sister came into the picture. And all the attention was off the sister, or was off the brother, and then it was over to the sister. The brother didn't like that. And so he was manifesting that almost stress in a way where he was ruminating, because he knew if he ruminated, then all of a sudden he was throwing up, and the parents were worried about that, and that's a way that he was able to get attention. Most of the time, it's involuntary, okay? I've had kiddos that can control it. They can go, oh, you want me to do it for you, Dr. Keith? So, and they'll take some milk, they'll put it in their mouth, and they'll swallow it, and 5 minutes later, they'll bring it right back up. So, I can't do it, don't ask me how to do it, but kids, they're good at it when they can do it. How do you fix it? How do you fix it? Diaphragmatic breathing. That's how you fix it. No medicine. Is it bad, ugly, or dangerous to the teeth? That's about it. Okay? It'll cause cavities because they'll do it multiple times a day. And it takes a little bit of acid to start to eat away at the teeth. Sometimes the dentists bring it to our attention. They'll tell the parents, they'll say, hey, like something's going on there. And then they'll come find us. So you fix it with diaphragmatic breathing. Who does diaphragmatic breathing? Psychology. So diarrhea. So concerning diarrhea, not as concerning diarrhea. So not as concerning diarrhea, acute onset, belly aches, vomiting, maybe a bug, maybe infection. You've heard me say that before. So a kiddo that comes in who's drinking a ton of Gatorade, drinks a ton of juice, that's toddler's diarrhea. Stop drinking the juice, things are going to get better. We see a lot of that. History of constipation. So parents come in and they go, he's pooping like 5 times a day. Can't get him to stop. And then you do a physical exam and he's got poop balls the size of baseballs all stacked up in his belly. So what he's having is he's having all that loose poop is going around those baseballs and it's leaking out into his undies. You fix the constipation, you fix the diarrhea, which isn't really diarrhea, it's just overflow and increases. Belly aches and loose poops. We see a lot of this. Irritable bowel syndrome, super common. So irritable bowel is defined as abdominal pain associated with the change in the form or frequency of pooping. So you either poop too little or you poop too much, or sometimes you alternate between constipation and diarrhea. But they'll come in, they'll poop 5 times a day, and they have belly aches, but there's no other red flag signs, and they've had this big giant workup by the pediatricians, and they're wondering if they need a colonoscopy, but they meet diagnostic criteria for irritable bowel, so you have to do a lot of education on IBS and how to fix that. Concerning diarrhea that makes me more worried. So chronic plus minus, because you can have irritable bowel syndrome for 5 years and still be growing and looking good. So I believe that one.
I have a question.
Yes.
How often and long are you seeing families of kids who might come in, like maybe you have a 6-year-old who's coming in with IBS and you're doing that education? What does that like treatment plan look like from your office's perspective? Is it monthly visits? How long does that kind of go on for?
So if we start them on medicine,
Mm-hmm.
then I'm going to want to see them back. And some patients go, they want to know what their diagnosis is. They want to know, is it bad or ugly? And they want to know what you're going to do about it. If you can check those boxes for patients and they're fine, then they may be fine with that education piece. So if we start medicine, and a lot of patients we do have to start medicine on for IBS, vast majority you don't, but the ones that make it to pediatric GI have been to urgent cares, they're primary care doctors, and they finally get to us. Usually we're starting some type of medicine on them. And if it's a medicine, then you'll see them back probably in about a month. And sometimes, it's not just about the medicine piece, it's about the psychology piece as well. And walking them through that as best I can as a medically trained doctor. I do my best to also hit the psychology. I'm big on the biopsychosocial model and looking at the whole person and not just the symptoms. And so sometimes it's a lot of talking about like how school, what's going on, like troubleshooting, like maybe we can get you in jiu-jitsu, like maybe it doesn't matter what that kid said about you. Like you're still a good person, and sometimes it's that, and sometimes that's all that they need.
Yeah.
So, concerning things for diarrhea. So, anything with blood obviously could be infection to inflammatory bowel disease, and I'm going to talk more about that in a second. Inflammatory bowel disease, Crohn's, and ulcerative colitis. Lots of blood coming out of the bottom. That's concerning for ulcerative colitis. An urge to poop while asleep. not normal. Usually when you're asleep, you're asleep. It's unusual to wake up at night with an urge to poop. When your brain is off, usually your GI tract is off. If you're waking up at night, red flag. If, again, biopsychosocial model, digging into the person and not just looking at the symptoms. Is there body dysmorphia there? Do they want to lose weight? What kind of activities is that person involved in? Do we need to be thinking about some type of an eating disorder where they're making themselves have diarrhea and losing weight? Dehydration, obviously, that's a big one. Especially if they're less than one, I've kind of already talked about that. And then tired or lethargic and you have diarrhea, you're dehydrated and you need to find an ER. Difficulty swallowing or dysphagia. So what could be on the differential when we see kiddos with this? So it depends if you're an adolescent or older or an infant here. So I'll kind of walk through that. Eosinophilic esophagitis, that's that asthma condition of the esophagus. Things love to get stuck because you have swelling in your food tube and you go to swallow chicken or beef or steak or hot dog, which I pulled out twice this week from kids' throats. It can't, the propulsion's not there. The relaxation's not there. So they go and swallow and it just puts on the brakes and it gets stuck. So reflux-related narrowings. We'll see this in kids with bad reflux. And it just causes inflammation and it will cause scar in the bottom part of their food tube. And now their food tube, the top works fine, and then it gets to a spot where it can't get through because of this chronic, long-standing irritation that's been there. Achalasia. Anybody know what achalasia is? Achalasia, and I saw a kid 2 weeks ago with this. So achalasia is where an adolescent, everything that you eat or drink gets caught, and it gets caught because your esophagus has inefficient push of food down, and the bottom stays tight. So it's a nerve problem and muscle problem. The propulsion and the nerves are not working correctly. So that's usually a surgical issue where that needs to be fixed. Pill esophagitis, we see this commonly. What's that? So typically it's with an acne medicine. I can't think of it off the top of my head, but I've seen it with multivitamins. Any pill that gets stuck, and it happens with a kiddo who's in a hurry and goes to practice, and they're trying to get out the door, and mom's like, take your medicine, or they're going to school, they pick up their pills, they dry swallow their pills, and then pills get stuck. And then they open up. And then they open up, and they cause caustic injury to the esophagus, and it causes a lot of pain, and the kids don't want to swallow. I'll show you a picture of that later, too. Blood vessels that come from the heart can push on the esophagus. So you can have blood vessels that come off of or around your heart that can actually press on the esophagus, where your esophagus is only 50% open. So you can have those aberrant or abnormally routed blood vessels that can smush on the esophagus. Infections, common. So yeast, you can get yeast in your esophagus. You can get herpes in your esophagus. Okay, you can get other viruses, cytomegalovirus in your esophagus. So all of those things you can imagine probably aren't just going to cause difficulty swallowing, but also pain when you swallow. So esophageal atresia. So that's where a baby's esophagus is not formed correctly. So that it goes down to a pouch. There's different types of esophageal atresia, but that's in a baby where they maybe go put an NG tube down into their nose, and you can't get it down very far. It stops. And that's found usually in the newborn nursery. Maybe they have poor tone. Maybe it was a difficult delivery, and maybe we need to be worrying about something like cerebral palsy. And I've already mentioned anatomy issues. So we see this. This is probably the most common thing that we see when it comes to difficulty swallowing in kids. We'll see it in kids as young as 1. Okay, adults have this. 6-year-olds have this. Teenagers have it. It's very
common. It's an allergic condition of the food tube. It's more common in kids with food with an allergy history. So they have asthma, they have eczema, they have
some allergic predisposition. That being said, we see it in kids with zero allergic predisposition, and why it's showing up in the esophagus, I don't know. So what are the symptoms? So in toddlers, it depends on the age. So in like 1 to a toddler, it would be like the kid's irritable, trouble feeding, vomiting, belly aches, poor weight gain. Okay, in an older kiddo, they're going to show up with like foods I can't swallow very well, or they're going to sit there and they're going to chew up their meal. It's going to take them forever. It's like Johnny's still eating. He slices up his meat really small, and he just takes forever. Like, hurry up, man. Family's done, right? That's because he can't get food down. And so it'll show up with abdominal pain, vomiting, like I already mentioned. They always have to get water. They always need water with their meals to wash out their food too. Problem is, there's overlap. For example, my kid's just a picky eater, and that's just how they always are. Or there is kids that have autism, they have rigid eating habits, right? I've seen kids that will come in and they're skinny and they need to put on weight, and they have, for example, autism, and they have rigid eating behaviors, and it's blamed on it's autism. That's what's causing it. And I don't know about that. Usually things don't get stuck in autism, but it's usually they're just really picky, and then you drive a scope down them. If they can't communicate with you well and they have horrible eosinophilic esophagitis, they just couldn't tell us that. So you fix that, the kids are eating like all-stars. So not every picky eater is just a picky eater. Sometimes there's more to the story. So you diagnose it with an upper endoscopy, you treat it with topical steroids. You've probably seen commercials about Dupixent, if you watch any TV, if you have time. And the risk of no treatment is these kids don't grow well, they get food impactions, and ultimately their esophagus gets narrowings and they get scar tissue, and they have to go in and get their esophagus dilated as an adult. Inflammatory bowel disease.
Everybody knows somebody with inflammatory bowel disease? Maybe? Nobody? Everybody? So this is common. It's way too common in kids, and the incidence is only going up.
This is Crohn's disease and ulcerative colitis. This is the, I had that on the first slide is organic and DGBI, or sensitive nerves. This is like the organic disease. This is the blood, the pus, the inflammation. That is this. So inflammatory bowel disease. So there are autoimmune conditions of the GI tract. So there's lots of factors that play into inflammatory bowel disease. It's a combination of, just to name a few, genetics, environment, diet, antibiotics exposure, stress, sleep. There's not one thing that you can do to say, oh, I'm going to minimize my chances of getting it. It's multifactorial. It can be caused or influenced by different things. It runs a lot more commonly in families than the general population. So if mom or dad had it, and you're seeing a kiddo with reflux, you better be on the lookout for inflammatory bowel disease popping up in their child. So it can be done. There's infantile forms of this. So I've never seen that. Those are all at the big IBD centers. But I've seen a kiddo at 10 months of age been diagnosed with ulcerative colitis. That's just incredibly early. So how does it show up? Bloody stools, diarrhea, unintentional weight loss, failure to thrive. They're eating like a Mack truck and they still can't gain weight. Like they're eating twice as much as their friends in football, and all they want to do is gain weight. All they want to do is be on the field with their friends, and they can't make the weight to be big enough to even be a safety on the team. So, that it shows up in different ways. We'll get them from endocrine sometimes because they go to endocrine and endocrinologists see them because they're not gaining height. It's not, endocrine's like, everything's good here. Their thyroid's good, their growth hormones are good, go to GI. And then we find small intestine disease, inflammatory bowel disease. We diagnose it with labs, imaging, and endoscopy. So Crohn's versus ulcerative colitis, they're two different things. Really, it's kind of a spectrum. They're not like, there's not a clear cut Crohn's. Sometimes it's an indeterminate. You kind of have features of both. You have to make your best educated guess. So Crohn's is anything from the mouth to the butt, anything in between. So aphthous ulcers. Anybody get aphthous ulcers here? You know, sores on the inside of your lip. Sometimes I get them. My kiddo gets them. So there are those sores that you get on the inside of your lip. Imagine having those all throughout your GI tract. So that's Crohn's. Okay. And with ulcerative colitis, so that's why it's patchy. That's why it's showing you can get it here. You get it in your small intestine. You can get it in your esophagus. With ulcerative colitis, it's usually just in the colon. So it's isolated to the colon. So with Crohn's, the disease could go all the way through the intestine. So it can burrow its way all the way through. So these kiddos will show up with abscesses and fistulas, which are holes where inflammation has burrowed its way through. And like they'll have a spot like in their underwear in the back, and it's not like they didn't poop, but poop's coming out somewhere. And that's because Crohn's has burrowed its way all the way through their intestine, and it's causing that much inflammation to allow actual stool to be leaking out where it shouldn't be leaking out. It shows up, so Crohn's may show up with abdominal pain. Crohn's likes to show up down here in the right lower quadrant. But it can show up anywhere, but it likes to show up where the small intestine connects to the large intestine. I've already mentioned you can have mouth sores with it. Sometimes you get some diarrhea. You're usually tired because you're malnourished and you're anemic. Sometimes you're going to have fevers as well. But these kids are going to be kids that are going to have a hard time gaining weight. Usually the big thing with ulcerative colitis, yes, it's abdominal pain, but it's usually diarrhea that goes into bloody diarrhea, and it doesn't stop. It's not, and with both of these things, they can kind of present like an infection. They can kind of present like a bug, like you went to Mexico. You had the all-you-could-eat buffet, right? Oh, we have lots of kids in our school that are sick. That's it. Time is the diagnostic ally when it comes to this. Time will tease out infection versus something like this. So this is an autoimmune condition that's not going to go away unless it gets treatment, versus time fixes infection because your immune system beats it and you get better. I see this a lot. The only reason I put this slide up here is because patients get irritable bowel syndrome and where's it? IBD and IBS. They get them confused. So if mom has IBD, I want to know that she has Crohn's, right? But if mom has IBS, I want to know that she just has IBS. So they'll say inflammatory bowel syndrome, and they get them messed up. And it's important to know which is which, especially when you're talking to the patient. I feel like, because they get them confused easily. So irritable bowel syndrome, not bad, ugly, or dangerous. IBD, inflammation, autoimmune, needs treatment, needs to be fixed. IBS versus IBD. So treatment for IBD, nutrition, anti-inflammatories. We can use anti-inflammatories by mouth. You can do anti-inflammatories through the rectum. Immune suppression medicines. There's another class of medicines I left off there, biologics or immune modulators. These come in the form of pills, shots, infusions. If the inflammatory bowel disease is bad and it's unrelenting, surgery is a possible option as well. So the goal with all inflammatory bowel disease in a patient is to control the disease. In a pediatric patient is to control the disease and allow them to be able to grow and thrive and do what they want. Treatment's lifelong and it doesn't go away. Feeding difficulties, we're almost done. I have the last 6 or 7 slides are all endoscopy pictures, and they're way more fun than this. Okay, so feeding difficulties, common things that we see. Okay, this is why I ask for y'all's help. infant pulling off a bottle or nipple resulting in suboptimal calories and growth. So usually that's a long history and a lot of time, digging through the weeds trying to figure out what's going on. So coughing or choking or gagging while eating or wet sounds after feeds. I'm a little concerned that kiddo might be aspirating, right? So MBS is a modified barium swallow. And I think probably a lot of people in this room know what that is, but for those that don't know what that is, that's where you focus a camera basically on the neck while they're eating, and you're looking to make sure that the formula is not going down into the airway. Instead, it's going down into the esophagus where it should be going. So you want to make sure that with wet sounding breath sounds after eating, you want to make sure that baby's not aspirating. Maybe they need, this is where y'all's magic is amazing. Like, y'all can fix that by messing with positioning, by messing with thickeners, by manipulating bottles, and you guys can tell me a lot more about that, but I've seen families come here with, I've come to clinic and I've referred them to you guys, and I refer to y'all as baby whisperers, because y'all feed babies and you just know, and you know how to fix them, and they'll come back and the parents come back and they're like, we're doing this now and we put on X amount of kilos and we are rolling and we are happy. And that first visit with me, we're talking like, well, these are all the things that could possibly happen, and well, what if that doesn't work? Well, then maybe we're talking about feeding tubes, but I don't really want to talk about that yet. And like, there's just spiral of thoughts that happen, and then by manipulating the thickness and flow and positioning, and maybe it's ties, maybe that's what the kiddo has, but y'all are able to see that with your eyes and fix that, and that's awesome. I love that. So maybe the babies are just having a hard time latching, and they need a lactation consultant. Maybe the mom's not producing enough milk. Maybe she doesn't feel full before a feed and empty after a feed, and maybe the baby's sitting there working as hard as they can, but they still can't get enough milk. Maybe they need supplemental formula. Maybe the mom needs to pump more, if possible. Sometimes you can have cow's milk protein allergy that lasts a long time, and it will cause a baby to be uncomfortable when they eat, and so they want to eat less formula, because when they eat, they hurt. And when they eat, they hurt, they take less formula, which equals less calories, which equals suboptimal growth. These are tricky kids, ARFID kiddos. Do you guys see those?
Yes.
Yeah? Okay. Need your help. So these are tricky kiddos. So these are the picky eaters. As I've already kind of hinted at, this is a team approach. I feel like a combination of nutrition and GI, psychology, even to try and help. I think as much as we want to say, hey, this really sounds like ARFID or you're a picky eater, as I've already alluded to, you always have to have disease in the back of your head, because we don't want to go, oh, it's just how you're wired, and then the kid have a disease that we're missing. So I never want to be that person that misses that. So we always have to have disease in the back of our head. Don't forget about eating disorders. Any eosinophilic esophagitis is causes for picky eaters or kids that just don't want to eat. GI bleeding. Blood,
Vomit or stool is always a red flag sign. It's never normal. So if that's happening, you need to find GI or your pediatrician at least to start. Upper GI sources
for bleeding. So stomach ulcers, we see those. We see esophagitis. I'll show you pictures of that. We see Mallory-Weiss tears. You know what Mallory-Weiss tears are? It's when kids throw up so much that they tear the bottom part of their esophagus. And when they tear it, they start seeing blood on like their second or third or fourth time. Usually it's on the first time that they throw up, because the first or second time the stomach has gone up through the lower esophagus. On the third time, it finally rips it, and then they
see blood that comes out. Lower GI sources, inflammatory bowel disease, talked about that. Polyps we see polyps in kids. Did you guys know that? We see polyps.
Infections also needs to be on the list. So, belly pain, diarrhea. I think I've hit a lot of this already. I'm going to mention these just because, and I think this is like my last-ish, yes, okay. This is my last slide. And the only reason I'm going to talk about this, I'm going to hit these one more time, is because 25 to 50% of the kids that we see have this. And in the
criteria for diagnosing a DGBI or functional abdominal pain, that book is like this thick. It's like this thick. And there's a limited number of those diagnoses. When you go to medical school and you learn about disease and pus and inflammation and blood and all the bad things that can happen to the body, that's in countless pages, countless books. So the DGBIs or the functional abdominal pain, there's a lot of information and a lot of
kids that are in this small book. The other half are in that big book, but it's just a lot more information and a lot more to go through. So irritable bowel syndrome, abdominal pain associated with changes in bowel habits. So super common, like in adults, it's like 1 in 4 people. So we see a lot of it. Dyspepsia, what's dyspepsia? That's where you have upper abdominal discomfort associated with nausea and early satiety. So that means whenever you eat food, you get nauseous, you feel sick at your stomach, and you feel full. Your eyes are bigger than your stomach is. So that pizza looks really good, or that meal looks really good, and then you get into it and you're like, I'm good. So irritable bowel syndrome is sensitive nerves in your colon. Dyspepsia, or functional dyspepsia is really what it's called. Functional dyspepsia is sensitive nerves in the top part of your stomach, okay? It's just North Pole, South Pole. It's just where the sensitive nerves are. Cyclic vomiting, I've talked about that. Abdominal migraines, I've talked about that. Functional constipation, we talked about that. Rumination, we talked about that. Yay, okay. So procedures, we're almost to the end. So procedures, so what do we do? So lots of people go, oh, like do you do surgery? Like we'll see kids for like hernias. Not the guy you want to do your hernia surgery, right? That's a surgeon, right? So we do scopes, we go through existing holes, right? So we don't cut anything. Technically, we take polyps out, and that's a type of cutting, but we don't use any knives. Lots of questions, like, do you feel the biopsies? No, kids don't feel biopsies that we do. The biopsies are teeny, tiny little biopsies. If I had a ballpoint pen, I do. So if I had a ballpoint pen, I made a dot on my hand. So if anybody can see that black dot, that's as big as our biopsies are. They're teeny tiny, okay? So they don't feel it. Pediatric anesthesia puts our kids to sleep. So we don't use adult anesthesiologists, okay? We use pediatric anesthesiologists to do that. There are day procedures. Upper endoscopy may take 10 minutes. A lower endoscopy may take 30 minutes. Everybody's colon is a little bit loopy and a little bit different. So if your colon's straightforward and is having a good day, then it doesn't take very long. But if it's twisty and turny, it takes a little bit longer. So common symptoms that may require an endoscopy: abdominal pain, difficulty swallowing, diarrhea with blood, blood coming out of the bottom, unintentional weight loss, vomiting, heartburn, if you're aspirating, or if you have foreign bodies. So I'm going to walk you through a couple of pictures, okay, and going to show you what we may see. So this is tracheoesophageal fistulas. So that's what I was getting at when we were talking about the baby, where the esophagus isn't formed, well, the esophagus and the airway isn't formed correctly. So they can be connected. They can be connected embryologically. And so they're not separated like it should be. There should be a gap there. So the most common one is this one that you would see, 86%. But let's say that you have a baby that's aspirating and you want to look further into anatomic issues. You've already put contrast down there, what's going on. Usually you end up doing a scope with ENT, and GI. You may even get pulmonary involved and do a triple scope. But this is showing you an example of not what I would catch, but what ENT would catch. That's a cleft. That's a cleft where there's a hole basically underneath there where formula should be going that direction, but because there's a small hole, it can snake its way through and go into the airway. So that's something that ENT can fix, okay? Here's a fistula. So that's the esophagus. That's the airway. That's the esophagus. that tiny little hole is connected to the airway. So every time formula goes down, a little bit of stuff goes down into the airway. Heartburn, chest pain. That's what pill esophagitis does. So this right here, if you can appreciate, like there's blood vessels, ironically this is normal, okay? I can see here it kind of doesn't look normal, but this is all normal. You can see where these holes are, that's where the pill was stuck. So it's a very localized area of lots of irritation and inflammation where that pill got stuck. That's candida in the esophagus. So that's what that looks like. That causes difficulty swallowing, that causes pain, okay? You need to give those kids diflucan, you need to give those medicine, that kiddo acid blockers and coaters to help coat those little ulcers that pill made. This is a typical picture that we would see. I scoped 2 kids this past week with this type of picture. So this is reflux esophagitis. That right there, those are just linear ulcers and white pus. So you can see every time a kiddo eats,
they would probably be uncomfortable and they would hurt. This continues to happen over a number of years. The esophagus tries to repair itself, and as it tries to repair itself, it replaces itself with scar, and that's where you get those narrowings.
Eosinophilic esophagitis. This is a normal esophagus, okay? There's nice pretty little blood vessels hiding up underneath here. This is what we want an esophagus to look like. That is not what we want an esophagus to look like. This is edema and fluid, and you get these little train track lines that go down. This esophagus isn't going to work very well. So this is when food gets
stuck. This is an example of food getting stuck. So that is a food bolus in an esophagus, and when that happens, patients can't swallow at all. They come in with a spit cup, and when food gets stuck in the esophagus, you have to go get it. And whether it's 2 in the morning or 2 in the afternoon, it's an emergency. You have to go get it. So especially when they can't control their secretions because they don't have anywhere to go. So there's airway compromise when that happens. So you have to go pull it out with an endoscope. And this is inflammatory bowel disease. Okay, this is a normal colon. These are not normal colons. Okay, this is an example of Crohn's. This is an example of ulcerative colitis. So you can appreciate that from across the room. Like that looks mad, that looks angry, that looks inflamed. That's disease. Ulcers, we see this a lot. What are risk factors for ulcers in kids? There's 2 big ones. It's easy. Motrin and H. pylori. Those are the 2 big ones. Okay, where do ulcers like to pop up? In the antrum here, and in the first part of the duodenum, and that's an example of a real ulcer there. So the problem with these is that they erode down too far and they find a blood vessel and then they bleed a lot. And then they come in and their blood count drops and they feel anemic and their blood count will go down to 3 or 4, scarily low. So that's ulcers. Foreign bodies, these are scary. So this is probably the most common thing that we go get is coins. Coins stuck in the esophagus. What's that?
Oh, a battery.
Yeah, I know. That's what I was just looking at to see if there's a. I'm gonna call it a coin. But so a battery looks like it has a halo, a double halo. It's what it looks like. There's a little line that goes in the middle. So and that's what this is showing: button batteries versus a child's esophagus. So and it's just showing you on a piece of ham. If you just put a lithium battery, you put it down there for, I don't know how long this was there, 50 minutes. If you put it down for 50 minutes, look what it does to the ham. Just
contact. So that's the problem, is that they'll burn holes through the esophagus. And what do you have around your esophagus? Your heart, important, major blood vessels that feed your heart, your lungs, the sac around your heart. So there's lots of vital organs around that area. So if there's ever a button battery in the esophagus, you got to go to the hospital. So that speaks towards, and the cool thing is now they're making those button batteries with they're like a bitter taste to them. So when kids put them in their mouth, they don't like it.
So they're making those. But be careful with those big ones. The smaller ones are still dangerous, but less dangerous. The big flat ones, those lithium-ion batteries, be careful if you have those rolling around your house. So, yeah, maybe that's a battery and that's a coin. But coins are super common. That's an example of a coin that's stuck. Screws, anything, earrings, anything. We have to go get this because it's sharp. These are bad. These are real bad. These are the high power earth magnets. Do you guys have any of those in your house? If you do, get rid of them. But they're usually like on an executive's desk, and they can make like little designs, and like they can, you know what I'm talking about? Like you can like put like 10 of them or 30 of them together, and they're all sticking. You can put one on one side of your hand and one on the other. Well, imagine if that was your intestine. Because what do they look? They come in all different pretty colors. They come in reds and greens and yellows, and they look like candy. And so kids go and put them in their mouth. When they put them in their mouth, they swallow 10 of them, and they swallow 10 of them over a 5-minute period, and they all kind of go down at different times. And then one gets close to the other, and they stick. And now they sandwich 2 pieces of your intestine together, and then it squishes the blood supply out, and then your intestine dies, and then you get holes everywhere. So these are really bad. So high power earth magnets, get rid of them if you have them in your home. Polyps, that's an example of a polyp. So we'll see this. These are kiddos that have rectal bleeding, and that's usually about it. They just show up with a little bit of blood. These are painless, but every single time they poop, they have blood. And so that eventually leads to an endoscopy. And then what this picture is showing is a little loop that's put out that goes around the base of the polyp, and then we burn the base of the polyp. We take those guys out, and we go about our day. So there are certain syndromes where you can have a lot of these, where your colon has to actually be taken out. But a majority of these are simple juvenile polyps, and that's all they are. So that's what any blood coming out of any hole, bottom line is, go to a GI.